Hi, this is Ryo Yamamoto. Today, I will be speaking about our study resuscitative endovascular balloon occlusion of the aorta, known as REBOA, and traumatic cardiac arrest. We know only a little about the REBOA for the patient with traumatic cardiac arrest. There are few studies from the United States, and one identified if we use the REBOA in the patient with traumatic cardiac arrest, blood pressure was increased and the rate of return of spontaneous circulation was also increased. The other study found that the REBOA during CPR for the patient with traumatic cardiac arrest, the patient had shorter duration of interruption of CPR compared with the RT. So we performed this study to eventually elucidate whether REBOA is a therapeutic option during resuscitation of traumatic out-of-hospital cardiac arrest. We hypothesized that REBOA will be associated with higher survival to discharge compared with RT. We used the Japanese nationwide trauma data bank, so Japan Trauma Data Bank, and this included more than 200 tertiary care centers. Our study included the adult trauma patients who were transported with the cardiac arrest, and also the patient underwent aortic occlusion by REBOA or resuscitative thoracotomy. So we divided all patient data into two groups. One is the REBOA group and the other is the RT group. The primary outcome was set as survival to discharge. We thought there might be many differences between the groups on some variables such as age, mechanism of injury, signs of life, and injury severity on the head or chest, and ISS, and also the CPR time before the aortic occlusion. So to adjust these biased distribution of the variables, we calculated propensity scores. Propensity score was calculated using the multivariate logistic regression, and the scores were obtained in the model. And we did an inverse probability weighting analysis known as IPW analysis with these propensity scores. So this is the patient characteristics, and if you look at the data on the left side, this is the data of the before the analysis, before the adjustment, so unadjusted data. We had only 144 patients in the REBOA group and more than 1,000 patients of the RT group. The patient in the REBOA group have more signs of life at scene and more signs of life on arrival. If you look at the data on the right side of the table, these data are after the adjustment by IPW. The biased distribution of the variables before IPW were successfully adjusted with IPW. So there is a significant reduction of the standardized differences, meaning the IPW could adjust the two groups successfully. And this is the primary outcome of our data, and left side is unadjusted data and the right side is IPW data. And blue column is a patient of REBOA group, and orange columns are patients in the RT groups. On both analysis, the patient in the REBOA group had higher rate of survival to discharge. There are several limitations in this study. The first, this database didn't have any data on indication of REBOA, size of catheter, the position of the catheter placement, and duration of inflation, and also the procedural complications. And also the 55 patients in the REBOA group, so that was 38 of the percent of 38% of the all patients in the REBOA group received subsequent resuscitated thoracotomy for the repair of the thoracic injuries. This definitely induced the drug interventions in this study, so we need to look at carefully at our data. So this is our conclusion. Thank you.